This lecture will cover image descriptions and an introduction to artifacts. Most of the terms that we use to describe our pictures should be reviewed in these next couple of slides here, but our first words that we like to use are comparison words. We use hyperechoic, hypoechoic, and isoechoic to compare tissues to one another. So hyperechoic is tissue that appears brighter. So the liver lesion is hyperechoic to the liver parenchyma. That means that it appears as a brighter or whiter echo. Hypoechoic then is tissue that appears less bright. The nodule is hypoechoic to the thyroid tissue. This would be an area on the thyroid that appears a little bit darker than the rest of the thyroid. Then we also have isoechoic. This is going to be the same level of brightness. The kidney nodule is isoechoic to the renal parenchyma, meaning it's about the same level of gray. So in addition to those comparison words, we also have descriptor words. We use homogeneous, heterogeneous, and anechoic to describe what we're seeing on our screen. So homogeneous would be the same echogenicity throughout the tissue. For example, the liver parenchyma is homogeneous, so it would have a very smooth looking echo texture to it. Heterogeneous then is different echogenicities within the same tissue. The endometrium is heterogeneous. So in this case, the endometrium would have lots of brights, lots of mid-grays, maybe some anechoic spots. It'd kind of be all over the place. It would look very non-uniform. And then we have anechoic, which means without echoes, typically black. The gallbladder is anechoic. Our heart chambers are typically anechoic. It's anything that is filled with fluid that should appear as black on ultrasound. So again, kind of recapping all of those words that we just went over. Here we have our liver lesion that is hyper or brighter than the rest of the liver. Moving counterclockwise, we have the thyroid lesion that is hypo or darker than the rest of the thyroid. Again, we have an isoechoic lesion because it is the same level of grays as the rest of the kidney parenchyma. We consider anything with fluid in them to be anechoic, so this gallbladder is anechoic. This endometrium here has a lot of different echoes within, so we would consider that a heterogeneous endometrium. And then looking at the liver parenchyma throughout here, it's very smooth, all the same level gray. We consider that homogeneous. So it's important to use these words to describe our findings, as we are not allowed to diagnose an ultrasound, but using these descriptor words will help with the radiologist to understand kind of what we're getting at. All right, so that was a quick and easy review of some of the image descriptors. Just a good time to throw them in because a lot of the artifacts that we talk about are going to kind of talk about how the pictures change on those anechoic parts or hyperechoic, hypoechoic parts are going to change based on the artifacts that we see. So just kind of an introduction into that. So the rest of the lecture will consist of artifacts, what they are, what causes them, the types of artifacts that there are, and how we can correct our artifacts. While we are studying artifacts through the next few lectures, make sure to record what causes them, what assumptions are being violated by the ultrasound machine, what hindrance they put onto our pictures, or possibly what helps them, and then also how we can correct it are going to be the main things that you're going to want to know for each artifact. So what is an artifact? An artifact is defined as an error in imaging. So this is going to manifest in our pictures as structures that are either not real, that are missing, that are in the wrong spot, or show up as the wrong brightness, shape, or size. So anything that is not true anatomy is considered an artifact. True artifacts arise from a violation of basic assumptions that the ultrasound is making in regards to how sound works within the body. There are also artifacts caused by interpreter error, operator error, and then we can also get some artifact caused by equipment malfunction. So most of our artifacts are going to come up because there is a violation of basic assumptions. you're going to want to know these 7 basic assumptions. Make sure that you understand what they are and how they affect artifacts on our machine. So the 7 basic assumptions: first, that sound travels in a straight line. Secondly, sound travels directly to a reflector and straight back. That sound always travels at 1540 meters per second. That the reflections displayed are found only in the main beam's path. That imaging plane is extremely thin. That the reflections are as bright as the reflector's characteristics depict, and that all echoes are received before the next pulse is sent. If we violate any of these basic assumptions, then an artifact is going to appear in our images. So again, remember these 7 basic assumptions. We're going to see how, when these are violated, how they result in artifacts. So we're going to get back to those 7 basic assumptions as we move through each of the video lectures for this class. We are going to touch real quick on interpreter, operator, and machine error though, as these also do cause some artifacts to appear in our images. So interpreter error would be any sort of anatomic pitfalls. The machine just can't handle what's going on with the anatomy, therefore we're not getting a true image displayed, therefore we are technically getting an artifact. So there are just limitations of ultrasound physics in regards to anatomy. We can't see through bone, so when we see, or when we're imaging and we get to a soft tissue bone interface, we can't see anything past it. We know truly that there is either more bone or tissue behind where that bone is, but we can't see it. So therefore it is technically an artifact because we are not seeing the true anatomy. We also can't really see all that well past gaseous structures, so lungs, gas within the bowel, all of that limits our visualization. We know there is true anatomy behind it, we just can't see it, therefore it's an artifact. And then even with large body habitus, if you have an overweight patient, we just sound attenuates, can't penetrate as far into the body as we may need to see all of the anatomy. Again, because we're not seeing true anatomy, it is technically an artifact. So those are interpreter errors. There's also operator errors. As sonographers, we can kind of induce artifacts into our pictures. So that might be the poor use of transducers and frequencies. We know a high frequency transducer is only good for superficial imaging. If you chose a high frequency transducer to do some deeper abdominal imaging, then it's an operator error. We're not going to see all the anatomy that we need to see, ergo we've induced artifact into our picture. Also using incorrect gain or incorrect TGCs. If we turn our gain up too high, turn our gain way too low, we're distorting the level of echo that should be coming back, therefore we're kind of making an artifact on our image. So those are operator errors that sonographers need to be aware of. And then we also have some machine errors that can occur. If you've tried changing your gain, tried changing windows, tried just different settings, and you still can't correct your artifact, then you might start to think that it's actually a machine malfunction. The biggest one that we see when we talked about it in the transducers lecture was that if there's a broken crystal, you usually get some sort of fallout from the top of the picture down through the bottom. That fallout is going to cause some black lines going across our pictures, therefore we're hiding the anatomy. So it is technically an artifact, but it's an artifact that can't be corrected. You need to fix the machine. So the biggest question that you're going to be coming up with scanning is deciding, are things actually artifacts? And if it is an artifact, do I leave it or do I try to correct it? So artifacts are going to appear and disappear depending on the window of insonation. If you're using a subcostal window and then move to an intercostal window, that artifact probably should have disappeared or have changed somehow to prove to you that it is an artifact. Most artifacts also can be corrected, leaving the true anatomy in the image. So again, changing your window, changing TGCs, changing focal points, that kind of stuff, we usually can correct for the artifacts that are there. So if you can move around an artifact, that helps to prove that it is indeed an artifact. Like I said before, we also wonder, should we leave that artifact in there? It might be helpful in diagnosis. There are gallstones. Part of their descriptor is that they have posterior shadowing. If there was a bright echogenic structure within the gallbladder without shadowing, then we'd start to think polyp. So it is sometimes helpful to leave artifacts in our pictures to help in the diagnosis. And that's also important to look for those artifacts while we're imaging, because uncorrected artifacts can lead to overcall and misdiagnosis. We have some artifacts that we'll learn about in a little bit here, but they're displaced structures put elsewhere within the body. So one time we were scanning a bladder, and a coworker of mine saw this huge cyst off to the side. She's like, oh my gosh, I don't know what to do about this. Is this what we're looking for? I can't really get a good picture on it. Well, the problem was that when she changed windows, then the artifact disappeared, and so she was struggling. She could only find it in one spot. So that should have been her first clue that it was an artifact. But what it actually was the bladder being superimposed off to the side of the true bladder, and so she thought it was a cyst hanging out in the pelvis. So uncorrected artifacts do lead to overcall and misdiagnosis. So it's important that we are able to differentiate between true artifact and true anatomy. The next 4 videos that we're going to talk about kind of breaks down artifacts into their types. So we have resolution artifacts, propagation artifacts, attenuation artifacts, and Doppler artifacts. All of those will be covered in their own video lectures. So you may have noticed already at this point that the video guides have changed a little bit, in that it's only 4 questions, or 3 or 4 questions, and it all falls under the test yourself category. These are going to be a little bit more critical thinking for this chapter, and I encourage you to write as much as you need to understand the concepts, and we will cover the answers in class. So number 1, what are the 7 basic assumptions the ultrasound machine is operating on? Number 2, explain interpreter and operator error. Number 3, what are the 4 types of artifacts? And number 4, I want you to think of a question you have about this lecture. If you really can't think of any questions, everything makes sense, then think of a test question that you know that you would get right. Sometimes being able to teach the subject helps to solidify your understanding of the subject.